Hi, Farmies. I'd like to talk to you about a medication that we use when our patients are having either a heart attack or a stroke. It is called Reteplase. That's the one on our list. You might also see it referred to as Alteplase, or you might hear it called TPA. So tissue plasminogen activator. That's what these medications, that's what they do. They activate plasminogen. So plasminogen is what we use, what our body uses to break down clots. So it is called a thrombolytic. Thrombo meaning clot, lytic meaning to break up. So the easiest way to remember this is a clot buster. We want to break up those clots as soon as possible. So if if this medication is going to be effective, it needs to be given as soon as possible. Anywhere between 20 minutes to 12 hours is the most effective time. After 12 hours, it's really not going to be effective. For your patient, it won't matter. The tissue has had too much loss of perfusion, so it won't be effective anymore after that. So this is how it works. For example, your patient's having chest pain, there's a blockage, Reteplase is given within 20 minutes to 12 hours, and the clot gets broken up. So what do we have to worry about? That sounds awesome, right? We broke up the clot, no surgery, no stents, no nothing. They just went in there and broke up the clot. So what about those little pieces? Where are they going to go? They could go further down and you could have another infarction. They could just move further down the line. That would be one problem. As this tissue is reperfused after you break up the clot, we could have some dysrhythmias. So we could have, here I'm going to make I'll make a little dysrhythmia sign. So here's your rhythm. It's could have a bad rhythm happen. But what we're going to have happening all over the body, because we've just given a medicine that breaks up clots, is we're going to have bleeding. So we want to stop the bleed. That is going to be your idea for interventions, stopping any bleeding. So you're not going to want to give them any punctures. You don't want to do any blood draws or any insert any IVs after you've given this medication, as few as possible, because they're going to keep bleeding. You might want to have a pressure dressing on something that is already, if they already have a wound of some sort, you would need to put a pressure dressing on it because the clot that had formed is going to now be clot busted. We're going to bust up that clot and it's going to start bleeding again. So you're going to want to have a pressure dressing, hold pressure on any existing wounds. This medication is great if the CVA that the patient had is related to a clot. However, if it is related to a hemorrhagic stroke, that would be contraindicated because we're going to cause an increase in bleeding in this patient. And there's no point. Like, why would we give a clot buster if there's no clot? So we have to make sure that we find out, have they ever had a hemorrhagic stroke in the past? Because we wouldn't want to give that. And then monitoring our patients is always key. We're going to monitor our patients' vitals. We're going to be watching out for these dysrhythmias. We're going to be watching out for any signs of hypotension or internal bleeding. So monitor, 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 and stop the bleed. Because again, risk versus benefits. If we're breaking up the clot that's causing the problem in the coronary artery, we're also going to be breaking up clots everywhere else in the body as well. All right, guys, that is it for Reteplase. You might also see it referred to as Alteplase or TPA. It is our clot busting medication. Have a great day.